All right, we are in the home stretch. I appreciate so many of you being here for the full day and getting through cannabis. Now, our last presentation is actually talking about all our kids who sustain injuries doing athletics and play, and how to sort of manage getting them back into the real world of returning youth athletes to sports post-injury. Some of this actually may apply to pediatricians who overdo it and injure themselves and have to sort of get back into the swing of things as well. Am I right? So we're going to finish up with the group from Children's, Kevin McGuinness, Janet Qiao, thank you, and Chelsey Bowman. So let's take it home. We appreciate you sticking out to the end, and we'll wrap up around 4:30 and get you all on the road. So thanks for being here the whole day. Thanks. Friendly crowd. This button advances it. Green button advances it. Right, if you have to go back. Just make sure the mic is close enough.
All righty. Can everyone hear me? All right. Good afternoon. My name is Jana Qiao, and I'm one of the sports medicine physicians working at Children's National. I am operating out of the Fight for Children Sports Medicine Center over at Silver Spring. Today, we are excited to share some insight into the collaborative process of recovering our young athletes from injury, and hope that from our discussion today, we can walk away with some strategies that we can incorporate into practice that will help parse out what can often be an intricate path in our pediatric population feeling comfortable and ready to return to sport. We present to you a clinical vignette of a patient that often comes into our clinic, and she is a 14-year-old female student athlete who is an incoming freshman. She's presenting for her pre-participation physical evaluation, or PPE, in July. She's been endorsing some knee pain for the past 6 weeks, but doesn't have a specific injury tied to it. She is a multi-sport athlete who plays soccer, basketball, lacrosse, pretty much year-round. Of note, she also is on a travel team for soccer that occasionally overlaps with other sports. And she has been, of note, training hard all summer to prepare for her tryouts in her high school team. And so taking us through a general physical exam, we can implement the tried and true IPASS acronym as a way to evaluate injury, which, as we know, stands for inspection, palpation, active range of motion, in which we should also employ passive range of motion, strength testing, as well as special testing. Specifically for the knee, it's important to just remember to evaluate the hip, as knee pain can present as a secondary pain symptom to SCFE, which will require emergent intervention. And so when it comes to strength testing, just make sure that you're comparing it to the other lower extremity as well. And you can also get a lot of information just simply by dynamic testing. So have them walk around, make sure that they're walking normally, implement toe walking, heel walking to see how their lower extremity strength is, as well as assess their squat and single leg hop to see if that exacerbates their knee pain. There are many excellent visual resources on conducting special testing, which can be useful in deciding if we want to go forward with some advanced imaging. And so I do pardon the video that has been playing in the background this whole time, but it has been illustrating an anterior drawer test, a Lockman test, as well as a pivot shift test, the last of which is a little bit trickier, but all of them effectively test for an ACL tear, which is a high yield study to see if you need any advanced imaging from the clinic onwards. And so as far as imaging goes, getting an X-ray is very helpful, especially in context of this patient who is coming in with a more subacute atraumatic knee pain. If you do order an X-ray, AP lateral views are perfectly fine, but I myself do end up getting 4 views in total, which are the AP, the lateral, sunrise or merchant, which allows us to look at the patella, and the tunnel view, which is a really good view for us to evaluate for any potential OCD lesions, which are very important for us to evaluate in a timely manner. In the ED setting, I've seen some oblique views being ordered, which are also very high yield for fractures. And then as far as additional imaging goes, when it comes to MRI or CT, perfectly acceptable to start ordering a CT if you have a high suspicion for fracture. But if you're worried about a tendon, a ligament, a fusion in a lot of cases, or even an OCD lesion, it's very appropriate just from a clinical setting outside of orthopedics clinics to order an MRI then and there for us to evaluate it further. And so this slide breaks down more common, more emergent reasons to send your patient to the ED from clinic or get evaluated in our clinic in orthopedics and sports medicine. Otherwise, if your workup is fairly nonspecific, it's very appropriate to actually put in a referral for physical therapy and have them get seen for a few weeks for their initial visit. It's also important at this juncture to also consider the athlete's resources. Oftentimes they're involved in schools that have athletic trainers, or maybe they have conditioning coaches or coaches that do have some PT certification. And so being able to remind them of these resources and allow them to incorporate that into their care allows us to bridge conservative therapy sooner, as it often takes a few weeks for an athlete to get seen formally by physical therapy. All right, so for the purpose of this vignette, our workup comes back non-specific. So as I'm evaluating an athlete or active individual, there are a number of questions I will ask them to get a better picture of the type of athlete that I'm taking care of. And so pain can travel, especially over this course of 6 weeks. It's important to identify if it's always been in the same location or if it's actually developed or gotten worse in different locations over time. It's also important to ask if the pain is only happening when they're doing particular sports or if they're actually having difficulty walking at baseline. As part of my evaluation, I'm also asking a lot of questions where I'm trying to understand the athlete a little bit further. Are they playing one sport? Are they playing multiple sports? Are they a seasonal athlete? Are they actually playing year-round? How many hours are they clocking in every single week? Is it overlapping with different sports? What does a rest day look like? Do they have a rest day? What does their hydration look like? How does their nutrition factor in? Are they incorporating snacks before their practice? And then the other element is also thinking about the training arena. I have field hockey players that play on turf, but there's actually concrete underneath. Are soccer players actually play on concrete, or is it gravel, or is it a very uneven terrain? All of these help tie a little bit of insight on why they might not be recovering the way that we want to. And then last but certainly not least, which we will have Dr. Bowman talk a little bit about in the next slide. It's also asking questions where we're teasing out the athlete as a patient.
Thank you. I'm Dr. Bowman, a sports psychologist here at Children's National in our Fight for Children's Sports Medicine Center. And I'm just highlighting that there's a lot of things that can impact recovery and a lot of things that athletes are usually not aware of that might be impacting their recovery. So we're going to thank you. That's why you're next to me. So we talked about inadequate rehabilitation. You're going to hear a lot from Kevin in a moment about how just like doctors and everyone, we're not all created equal. Not all PTs are created equal. So the rehab can really look different. Dr. Qiao talked to us about the lack of recovery time. We're seeing so much sports specialization, which we know is really harmful for young athletes. So they're not taking time off and they're playing only one sport. So much repetitive motion. Of course, social determinants of health affect everything and are at play here. We know there's a shortage of athletic trainers, especially in the DMV area. There's not safe outdoor spaces for all kids or places for them to do their rehab. We do know that caregiver factors matter, especially with the explosion at the collegiate level. We're seeing kids as young as 8, 9, whose parents are telling us that they're going pro, not even to college, that they're going beyond college and they're going to be pro. And while I do think my 10-month-old has a great arm, I don't think that's probably the destiny. There's a lot of money tied up and a lot of parents are getting really preyed on. I just heard of someone paying $2,000 for a recruiting coach for their middle schooler. So that excessive pressure, right? You just paid $2,000. Now your kid's not even playing the sport, can put a lot of pressure on kids to recover and get back. We talked about these lifestyle factors, and I'll pop on here later to really chat about some of these things. And then, of course, psychological concerns. We should, great that we came after cannabis use. Substance use disorders play a factor here, but we'll be talking about fear of pain and low mood. And no, we of course do not expect all of you or anyone's specialty to address all these issues, but sometimes keeping these things in mind can both remind us why our patients aren't rehabbing or returning to sport on the timeline we want and when we might want to get specialty services involved.
So jumping back into this vignette, you identify this patient's pain to likely be in the context of patellofemoral pain syndrome. At this juncture, it's very appropriate to advise some activity modification and referring to physical therapy at this time. I will now hand over the talk to Kevin, who will help illuminate some of what goes on during PT.
Thank you, Dr. Qiao, Dr. Bowman. Good afternoon, everyone. My name is Kevin McGuinness. I'm one of the physical therapists and a board-certified sports clinical specialist at the Fight for Children Sports Medicine Center. And I want to kind of briefly go over what the role of physical therapy for getting this athlete from injury back to play looks like. If you treat adolescent athletes, having a good physical therapy practice or physical therapist you can refer to and rely on is an invaluable tool for these athletes. So I'm going to be talking about what they should be doing, what kind of things that patient can expect, what kind of questions you can be asking of the patient to make sure that they are getting quality care. Unfortunately, one of the things we often see when athletes come from outside and we test them for readiness to return is just they have not been worked hard enough and they've been just going through the motions in PT for so long. So just because they said, yeah, I've been to PT twice a week for 6 weeks and I'm not better, maybe let's dig into that a little bit more and see exactly what they've been doing. So ideally, that therapist should be trying to do an individualized assessment where we're looking at flexibility, balance, strength deficits, looking at what this individual is presenting with that might be either from this impairment or causing this impairment in the first place. From that, they should be getting an individual progressive plan. They should be getting pushed hard in the gym. They should be getting a home exercise program. It should be difficult. These kids are doing very, very hard things on the field, so the PT needs to be hard. That therapist should also be able to help you coordinate with their other healthcare providers, their coaches, their trainers. Like Dr. Qiao and Dr. Bowman said, there's often quite an ecosystem around these young athletes of athletic trainers, coaches, strength coaches, position coaches, if you have specialists like baseball pitchers, who you want to involve in this process because they all have information, insight, expertise into this kid that you may not, and they have a big part to play in a multidisciplinary approach. And then finally, they should be able to do some testing to help you determine if and when that kid is actually ready to play again and have a pretty high level of confidence that that injury is not going to flare up when they get back on the field. So for this specific patient, a good therapist is going to be looking at a couple of things. We're going to be managing their pain. We're going to be managing them swelling if there's anything present. Get the joints moving normally, get the whole lower body and core strong again, not just the knee, addressing the joint above, the joint below, as we'll get to in a minute. It's very important. And then providing a roadmap for a gradual return to activity, not just doing leg raises in the PT gym for 6 weeks. And then the first time they touch a soccer ball is on the field. There needs to be some type of bridge from one to the other. So, some questions to ask about whether or not your patient is actually receiving high quality care. What are they doing when they're in physical therapy? If they're sitting on the bike for 5 minutes, getting a massage for 5 minutes, and then getting an ice pack and electric stim for 20 minutes, that is not therapy. That is just passive pain management. Those are nice feeling modalities. They will occasionally be useful at the start of therapy to get some buy-in, to get pain to a controlled point. But if there's never a progression to exercise, to running, to a home program, it doesn't even really count as therapy. So if that's all they're doing for 6 straight weeks, we probably need to refer them elsewhere. Our therapy needs to be active. The whole RICE strategy of rest, ice, compress, elevate can be useful, again, for brief periods for pain management, but the vast majority of their recovery should be movement-based, treatment-based, active, them doing things, not just resting and waiting for things to feel better. That's just a good way for them to get to further decondition, further sensitize to pain, and kind of delay their return. If they are only being given knee exercises and the PT has never looked at their foot and ankle complex, at their hip, at their core strength, at how they're moving overall, again, kind of a red flag for me. We know, especially in these young athletes, knee injuries either are caused by foot and hip issues or can lead to subsequent foot and hip issues through deconditioning. But either way, they definitely need to be addressed in these type of patients. And then the return to activity, right? We need to get them running again. We need to get them changing direction. We need to provide a roadmap for them to do that in a safe, progressive, linear, logical way, and make sure that we are not just taking them from doing stationary exercises in a PT gym setting, giving them clearance to play, and then the first time they've kicked or run is their first practice back. That's another recipe for a flare-up. And then I personally like to see my athletes until they are full participant in sports. Even once I've coordinated with their referring provider, with their psych, and everybody's on board that they are allowed to play, I want to help them manage that return to play. Because even if they're healthy enough to play a couple of minutes, they may not be playing a full game to start. And we don't want to hold them back until they're ready for a full game. That's not really helpful either. We kind of use this 25% rule. It's a heuristic. It is not evidence-based, but is one that's often cited in sports medicine. So if you say have an athlete who's a soccer player, 80-minute game, they get 20 minutes of play their first game back. If they tolerate that for a game or two, we bump it to 40, so on and so forth. So again, even once they are playing, we're still talking about a gradual return as their fitness returns. And then lastly, this is something that a lot of therapists, probably more therapists than not now, are getting very good at, is doing a battery of return to sport tests, because we know no single test, no single metric can tell us whether or not an athlete is ready to play. And whether that's an ACL injury, an elbow injury, a shoulder injury, all of these things we feel better about if we can get a bunch of data points that say they have recovered, they've gotten their symmetry, their strength, the normative value of that test has returned. And so most therapists are going to be doing a battery of sports tests, especially in the lower body. It's become very standard practice to do a series of hop tests, balance tests, patient-reported outcome scores, and providing a report to the patients that often they can provide to you to include as part of your follow-up care. And lastly, therapists should be using patient-reported outcome scores. These are questionnaires specific to body parts, specific to injuries, that allow patients to essentially score themselves, right? You can ask an athlete, how do you feel? 0 to 10, what's your pain? 0 to 100%, how recovered are you? These questionnaires are usually 10 to 30 questions long, and we'll ask a very pointed series of questions to try to distill an answer and give us basically a number so a patient can describe how well they are feeling and where they are in the recovery process. And often if we see an imbalance between these subjective reports on the patient-reported outcome scores and then my objective measurements that say, well, they're strong, but they're lacking confidence, that's another great indicator that maybe sports psych is the next referral that we need to include in this process. And a number of these are available at orthotoolkit.com, many of which you can actually fill out online and they will score for you. So you don't even have to worry about how to learn doing these scoring things or printing out PDFs.
All right.
Back to Dr. Qiao.
So our patient ends up coming back in a few weeks, and after a few sessions of PT, essentially they've reported that they've had some slight improvement in pain, but they're still self-limiting in sports participation. They're not really quite where they want to be. You ask the questions that Kevin had mentioned. Turns out they've completed about 4 PT sessions, which is a decent amount, likely spanning over about, anywhere from 2 to 4 weeks, not yet discharged from their care, as they haven't essentially been returned to play. And essentially, as you start to ask the additional questions that we've been talking about through this presentation, you start to pick up on the fact that she's been expressing a little bit of worry about returning to play, maybe getting a little bit discouraged about this diagnosis and the progress that she's been making. This is something that our patients can be very forthcoming about, but other times it might end up boiling down to essentially your intuition as their pediatrician. More often than not, you've essentially worked with them over the years, you've developed a bit of rapport with them, you start to recognize that this isn't really the patient that you had seen before the injury ended up taking place. Other times it's a little bit harder to parse out, but maybe the parents will end up picking up on this and they'll mention that they're not quite the kid they used to be. They might have lost their spark. And so at this juncture, when you're kind of navigating this process and getting this overall picture, if there's any part, in their appointment where you get a sense that there's might be something else that could be affecting more than just their musculoskeletal health, it is very appropriate at this juncture to start thinking about the resources in the DMV and more specifically thinking about referring to sports psychology.
I went too far. How do I do this? Okay, so just to really highlight this interplay of the physical and psychological factors, as you all know from seeing your patients who have psychological concerns, we have stigma around it. The stigma is still really high, particularly among athletes. So sometimes really highlighting that the brain controls the body is really helpful for our athletes. And if they're going to spend so much time in rehab and taking care of their knee and their hips and their ankles, shouldn't they also take care of their brain? So you'll see in the cycle here, right? We start with that self-limiting activity, which is appropriate with pain, but that can lead to a temporary loss of identity. When we think of the patient we described, right? She's going out for her high school team. There's probably captain's practice and coach's practice. She might be sitting one of those practices out. So she might not be there. She might be at home. She's not bonding with the team. She's kind of missing out on those things. That can, of course, lead to some temporary low low mood. When our mood is lower, we tend to nap. We may use substances, thinking of our last presentation. All of this can really disrupt, and the lack of structure can really disrupt our sleep at night. And this can increase a lot of worry about re-injury, which is harder to manage. And so when we have worry about re-injury, we'll see patients avoid certain exercises in rehab. And as Kevin said, if they're not with a physical therapist who's attuned to this, they might just be not squatting or not doing something. And of course, then they're going to be deconditioned, not ready to return. And we see that ongoing pain. So when we're facing that temporary loss of identity and low mood, we usually see they're not going to as much practice and not seeing their teammates as often. And the game plan as a pediatrician is you can encourage alternative activities during practice, right? Even if you're having them hold out or self-limit, help them brainstorm or suggest to them that they talk to their coach. What else could they do? Can they keep stats? Can they do their rehab on the sidelines? It's really hard for athletes to have to go to practice, have to go to rehab, do their at home, do their academics. So how do we make it a little bit easier for them to rehab and still be part of the team? We also know that just letting them know that besides competition and play, there's probably other aspects of being an athlete that they really enjoy, like teamwork or leading. And there's other ways that they can build these skills. So reminding them, you all know them really well. Well, what about that math club you are interested? What are other ways you can strengthen these skills and bring them back? And that's a lot what we'll work on goal setting and values identification in sports psychology. So for fear of re-injury, often we see a lot of worries about having even a more serious injury or missing even more time, right? Well, I missed now. What if I miss playoffs? What if I miss sectionals, nationals? And this is really, really common. So for that, we really want to coordinate closely with our PT and make sure that they're doing gradual exposure, right? The way to build confidence is to go slowly towards the things that scare us. You can go faster if it works for you. And so bringing in sport drills, making sure that they're, not going right back to a game. We actually see that quite often. We want to make sure they're in practice. They're starting with small drills, helping them brainstorm. And then, encouraging use of evidence-based coping strategies as you do with any psychological concern, helping athletes, if you know any examples, a lot of famous athletes these days are talking about their sports psychology or their mindfulness or the work that they're doing to keep themselves in tip-top shape. So kind of referencing that, having them look at the NBA playoffs, watch athletes or the WNBA, take a deep breath at the free throw line. All of those can be really important and sort of reducing that stigma and showing these skills work. And I know, as we just talked about, there is so many sleep difficulties going on. And we know particularly for high school athletes, they are not sleeping enough, and high school students generally aren't. But we usually see with the loss of structure for all adolescents, but particularly our adolescents or athletes, we can see more napping, going to bed later. They're not used to not working out, so they're just not as fatigued generally. They spend more time on social media. Maybe they're using cannabis or alcohol because they're also not, worried about being on the playing field. So obviously there's lots of really good sleep hygiene strategies, but I really emphasize to my athletes, well, you're telling me you want to go back to sport, but you're currently sleeping from 3 to 5 and you have practice from 3 to 5. So we got to stop that habit. And I also really try to talk about this being an untapped resource for athletes, right? If professional teams are bringing in sleep psychologists and sleep coaches, well, what if an athlete uses this rehab time to further their body and their whole health here? So that can be really helpful to get some buy-in and kind of get them to move the needle as a leg up. I also emphasize that sleep has been shown, adequate nighttime sleep has been shown to reduce musculoskeletal injuries. So if you have that fear of re-injury, we can talk about how taking control of your sleep can help prevent those injuries.
So coming back into this vignette, we love a happy ending, but we indeed have many patients who end up presenting in this way, and in fact do particularly well with a multidisciplinary approach in recovery to sport. So in this scenario, I'm seeing this patient, they're doing fantastic. They are in full participation in practice, and I'm evaluating them on exam, and they're essentially at baseline with respect to their range of motion, their dynamic testing, as well as their strength testing.
And then in their final PT appointment, hopefully we have done some return to sport testing, and we're looking usually at limb symmetry index, comparing the healthy leg to the injured leg in this instance. And we're seeing high scores across both their strength testing and hop testing, as well as a fairly high score on the PDI-KDC, which is a very common patient-reported outcome score for pediatric knee pain. So the therapist is happy there too.
And then from our sports psych, we're seeing that they're starting to learn some coping skills. They're using them. They're starting to build that habit and routine. We're seeing some decreased worries about re-injury. It is normal to still have worries until you've fully returned. So we normalize that. And then hopefully we're seeing this increased nighttime sleep and decreased daytime sleep.
So in summary, a lot of times non-specific injuries can be complex and can have many different factors that attribute to slow recovery or unchanged pain. And so from a primary care standpoint, pediatricians truly offer the most comprehensive insight to understanding developing athletes as people, and identifying these risk factors that contribute to sports recovery just based on your longstanding relationship with these patients. And so it in a lot of ways ends up boiling down to asking a lot of the right questions, synthesizing questions with respect to their sports routine, who they are as an athlete with the patient, so that ultimately we can all collectively facilitate an efficient way of getting orthopedic, sports psychology, and physical therapy specialists involved in their care.
And just in case you're looking to collaborate, we have the Fight for Children Sports Medicine Center. You can use the QR code and go to our page to learn more. But we're the first facility in the DMV that's fully dedicated to pediatric sports medicine. So all the staff that you see there have a specialty in both pediatrics and sports, which makes us really unique and are always happy to partner and help out.
And then one final offering we wanted to highlight. Unfortunately, we could not have a member of our engineering team with us here today, but we also do have a full service 3D motion capture analysis lab, which is absolutely incredible. And if you can ever have a chance to come visit and see it, you should. But we offer multiple services there, and we're currently developing more. We do a gait analysis service for patients with neuromuscular disorders, as well as a sports injury prevention service. Right now we have an ACL focused one, but we're also developing a golf swing and a pitching throwing program as well.
And then just lastly, we wanted to thank all of you. It's the end of the day. And our co-authors who work with us at the Fight for Children Sports Medicine Center. We do have some handouts over there if anyone wants more information with resources like ortho tools and some other helpful places for athletes to get more info. Thank you.
Thank you.